Let me start. Thank you so much for helping. My name is Yuko Harada from Kawasaki Municipal Ida Hospital. Our presentation is effectiveness of I-BMIPP myocardial scintigraphy in breast cancer patient. Next slide, please. Next slide, please. Cannot move myself. Can anyone help to move it? Okay, we have no COIs to disclose. Next slide, please. Next, please. Next slide, please. Okay, thank you. Cancer therapy has advanced and 5-year survival. Could you go back to one slide, please? Could you go back? One? Nope. So this is, can you go back to 2 slides, please? Okay, yes. Next one, please. Next slide, please. Thank you. Cancer therapy has advanced and 5-year survival has improved over decades. However, cancer patients suffer from cardiac toxicity of chemotherapies and or radiotherapy. Cardiovascular disease caused by cancer therapies is called cancer therapeutics-related cardiac dysfunction. Next slide, please. Next, please. CTRCD includes cardiac injury, cardiomyopathy, and heart failure. In most cases, CTRCD points to heart failure caused by chemotherapies. It is essential to detect CTRCD at an early stage to prolong patients' lives. Next, please. Next, please. Last year, European Society of Cardiology has established the first guideline on cardio-oncology. ESC guideline uses the term cancer therapy-related cardiovascular toxicities, including cardiomyopathy, heart failure, myocarditis, vascular toxicities, hypertension, cardiac arrhythmias, corrected QT interval prolongation, pericardial and valvular heart diseases. The term CTRCD is recommended to use for cardiac injury, cardiomyopathy, and heart failure caused by cancer treatment. Next, please. Diagnostic criteria of CTRCD in the latest guideline. Definition of severe CTRCD is new LVEF, which is ejection fraction reduction to 40%. And definition of moderate CTRCD is new ejection fraction reduction by 10%, new ejection fraction reduction by 10%, and also decline in GLS by 15%. Next slide, please. Next slide, please. This is also taken from the latest guideline, recommendations for cardiac imaging modalities in patients with cancer. Echocardiography, 3D echocardiography, or GLS, or a CMR, which is cardiac MRI, or a MUGA, which is isotope imaging. Next slide, please. Problems of each imaging. Several modalities were recommended, but each imaging modality has some problems. As for ultrasound, the problem is dependent on operator skills, complicated by patient's body, inter-observer variability, image quality. As for multigated radionuclide angiography and MUGA, radiation exposure is a problem, and also limited structural information beyond LVEF is also a problem. As for cardiac MRI, contrast agent cannot be used for CKD. Next slide, please. Then we focus on a new imaging modality, that is I-BMIPP dual isotope cardiac scintigraphy. This is widely used in Japan to detect myocardial damage. Iodine, beta metal iodophenylpentadecanoic acid, I-BMIPP, is a tracer for metabolism of fatty acid, which is known to account for more than 90% of myocardial energy requirements. I-BMIPP is typically utilized in dual isotope myocardial scintigraphy with thallium. So this is our hypothesis. I-BMIPP dual isotope myocardial scintigraphy should be useful for detecting CTRCD. Next slide, please. Next slide. Breast cancer patients, sometimes unable to undergo UCG due to surgery wounds or radiation scars. First choice of chemotherapy is cardiotoxic agents such as anthracycline or trastuzumab. The other anti-cancer drugs for breast cancer also have cardiotoxicity. When UCG is difficult to perform, I-BMIPP myocardial scintigraphy will become the preferable second choice screening test for CTRCD. Next slide, please. 100 out of 114 breast cancer patients who received chemotherapy for at least 2 months within 3 years were involved in the study. Anti-cancer drugs are given in accordance with the guidelines of the Japanese Breast Cancer Society. All patients underwent UCG prior to chemotherapy and every 6 months during chemotherapy. Patients fasted for at least 6 hours prior to the study, then were injected with BMIPP and thallium intravenously. Single photon emission computed tomography SPECT images were acquired starting from 15 minutes after tracer injection using a digital gamma camera. Next slide, please. Heart Risk View as software is automated software program to analyze myocardial SPECT images. It generates polar maps of the heart from myocardial SPECT data divided into 17 segments, calculates the mean percentage uptake count for each segment, and deployed the percentage in the 17-segment model. The mean percentage uptake count for each segment was recalculated, eliminating the effect of artifacts. Uptake counts were converted to scores using a 5-point scale from normal to absent. Scores were deployed in 17-segment model as final result. Next slide, please. This is the 17-segment model. AHA, American Heart Association, recommends to use this model to show the result of cardiac scintigraphy. The isotope uptake scores were deployed in this model. Next slide, please. The table is showing anti-cancer treatment of patients involved in our study. Paclitaxel was used for 90% of patients. Ipirubicin, which is adriamycin, was used for 62% of patients. Trastuzumab was used for 49% of patients. Next slide, please. Next slide, please. Evaluation with UCG. Measuring LV ejection fraction was not possible for 9 patients due to anatomical issues such as surgery wounds, radiation scars, or implants. 4 patients were diagnosed with CTRCD according to the criteria of LVEF lower than 53%. No symptoms of heart failure were observed in spite of low ejection fraction. Next, please. Next slide, please. 6 patients were diagnosed with CTRCD out of 100. Diagnostic criteria used here is LVEF lower than 53%. Adriamycin was used for 4 cases. Trastuzumab was used for 4 cases. Paclitaxel was used for all cases. Next slide, please. I-BMIPP dual isotope myocardial scintigraphy was performed for all patients. SPECT images, polar maps with 17-segment model were created. Heart risk view scores were deployed in 17-segment model. Next, please. Next slide, please. This is the cardiac scintigraphy of a patient with CTRCD. The left half is thallium perfusion scintigraphy. Left top is SPECT image, and left bottom is polar map with 17-segment model. The right half is BMIPP metabolism scintigraphy. And as you see, thallium scintigraphy is also almost normal, which means perfusion is normal in this patient. BMIPP scintigraphy on the right side showed decreased isotope uptake in the septum, apex, and inferior wall. When the isotope uptake is decreased, the software calculates damage score and deployed in 17-segment model like this. Next slide, please. Okay, this is another cardiac scintigraphy of another patient. Left half is thallium perfusion scintigraphy, and right half is I-BMIPP metabolism scintigraphy. Thallium perfusion scintigraphy revealed decreased thallium uptake in lateral wall and inferior wall. I-BMIPP uptake was remarkably low in all areas. However, the patient's LV ejection fraction was normal, 74%. The patient was suspected to have CTRCD in spite of normal ejection fraction. Next slide, please. We added the scintigraphy scores. One more click, please. One more click. Yes, thank you. We added the scintigraphy scores to the previous table of CTRCD patients. However, LV, EF, ejection fraction, and the scores of scintigraphy did not appear to be correlated. Next slide, please. This is scatter plot of LVEF and heart risk VUS scores for thallium uptake reduction of all 100 patients. Pearson product moment correlation coefficient was 0.049, which is an indicator of non-correlation. It shows that LVEF and the scintigraphy scores are not correlated. Next slide, please. This is scatter plot of LV ejection fraction and heart risk VUS scores for iodine I-BMIPP uptake reduction of all 100 patients. Even after omitting 2 outliers, Pearson product moment correlation coefficient was minus 0.085, which still indicated non-correlation. Therefore, both thallium I-BMIPP uptake reduction were not correlated to LV ejection fraction. Next slide, please. Even though the scintigraphy was not related to LVEF, we found an interesting pattern of I-BMIPP uptake reduction in the patients with breast cancer chemotherapy. All the scores in each segment were summed up, and segments 6, 12, and 16 revealed lower scores. There's the areas covered by left circumflex artery of the heart, and middle segments from 7 to 15 revealed higher scores, which means the middle part of the heart, but between basal ring and apex, was more damaged, probably by chemotherapy. Next slide, please. Comparison of LVEF and heart risk VUS scores did not reveal any correlation. Cardiac scintigraphy is not a new imaging modality replacing with UCG, ultrasound. The isotope uptakes were not correlated with LVEF. Therefore, myocardial perfusion and myocardial metabolism were not related to the dynamic function of myocardium in our study. This may be because the cardiac damage of the participants was mild or early stage. All patients were asymptomatic, and 87% of patients showed normal range LVEF. Next slide, please. Iodine I-BMIPP uptake revealed a mismatch with thallium uptake as expected. Distribution pattern of heart risk VUS scores was analyzed to show how and which part of the heart was damaged by chemotherapy. Middle portions of the heart, which is mid-cavity ring and apical ring of 17-segment model, were shown to be more damaged. Segments 6, 12, and 16 revealed lower scores. It may therefore imply that left circumflex artery area was spared from damage. Next slide, please. The result of this research constitute observational findings from scintigraphy that have not been therefore used to evaluate CTRCD. UCG should therefore be the first choice for diagnosis, as it is less costly and less invasive than scintigraphy. Alternatively, for patients who cannot undergo UCG ultrasound, myocardial scintigraphy may become a second choice. Nuclear cardiologic technologies visualize pathophysiologic processes at the tissue level. Therefore, myocardial injury could be detected at an earlier stage. Next slide, please. Myocardial scintigraphy is useful to detect CTRCD, but cannot serve as a perfect alternative to UCG. I-BMIPP myocardial scintigraphy will become the preferable second choice screening test, as it could point out the early stage of CTRCD. Next slide, please. Thank you for your attention.